All right, good morning, everybody. So my job here is to inspire, it's to explore, it's to educate, it's to challenge you all about emergency medicine and where we should be moving. And I'm hoping that at the end of this, I'm actually going to give you something that you can change tomorrow or the week after your next shift when you go in, something that you can do differently about how we're providing emergency care now. This is Bellevue Hospital. This is where I work. In 2005, I was fortunate enough to be selected to do my intern year there. We always kind of joked around that there was probably some confusion. There was another medical student from my institution, very similar name. Not sure they could tell us apart. They just took us both, figured it would kind of sort itself out over 4 years. And when I walked in there, I felt that I was going to be educated by the greatest minds in emergency medicine, some of the founding fathers of our specialty, were going to teach me to be an amazing emergency physician. That's what I wanted. And my intern year was ups and downs, but it was mostly ups. And I think there were cases from that year that I still remember. I'm sure that you guys have these memories. The cases that we see early on in training become imprinted on us. They change who we are. I remember those cases better than I remember cases I saw last week. And they always stick with me. And there was one particular case that really has stuck with me that I think about almost on a daily basis or a weekly basis. It comes back to me. So I was about 4 months into my first year of training. Patient came in, and he was tachycardic, he was tachypnic, he was hypoxic, he was hypertensive, and overall, he looked like shit. He looked like he was dying. So I went to see him with the attending. We used our stethoscope because we didn't really use diagnostic ultrasound back then, and we heard crackles to his apices. And so I was formulating some ideas in my head, and I looked at the attending. The attending looked at me and said, "He's got fluid in his lungs. We need to get it out." This is a very smart attending. He went over and wrote an order for 80 milligrams of furosemide. Clearly, the patient needed to be volume out of his lungs. So we gave him that 80 milligrams of Lasix. I went back and I checked on him 15 minutes later, and the patient looked worse. So we gave him another 80 milligrams of Lasix. And we went back 15 minutes later, and he looked worse again. And, I went up to the attending and said, "I know I'm new here. I know I just started, but I listened to this lecture about acute pulmonary edema, and that these patients, they don't just need the volume out, they need it shifted, they need nitrates, they need respiratory support." And he looked at me and said, "He's got fluid in his lungs. He needs more Lasix." So we gave him 160 milligrams of Lasix. Needless to say, the patient ended up intubated and went up to the CCU. And I figured, maybe we went wrong, but the CCU guys, they're smart. Intelligence increases as you go up in the hospital. That's why I work on the first floor. They're going to get it right. And so I went and followed up the patient, and he was on a Lasix infusion, and that's it. And he had a bad outcome. And so I thought about this case, and I thought about it, and we hate those talk and die moments. The patient who comes in alive and doesn't leave us in the same state. And so it really resonated with me, and I thought, how could we have done better? I knew what the disease was. I think I knew what to do, but we didn't do it. Where was that disconnect? And that's where this idea came to me of thin slicing disease, something that I've been thinking about again for 11 years. I've been trying to formulate these ideas and put them together. And finally, Chris Nixon said, "Why don't you just do it at SMAC?" Oh yeah, no problem. Let's just do it at SMAC. That'll be okay. So 11 years of thinking about this case, and then 6 months of trying to make something sensible out of it. Now, when we think about the idea of thin slicing, there's a pop culture term, a pop medicine term that we think of. It's this idea that we can make these quick inferences about a state, about a situation, with minimal information. And that minimal information, those quick inferences, are sometimes better and more powerful than where we would reach with more information. But that's not really what I want to talk to you guys about. What I want to talk to you about is the fact that we should be thin slicing disease into a spectrum. All disease exists on a spectrum. It exists on a spectrum from urgent to critical. And we have to be able to take that umbrella term and spread it out into that spectrum so that we know how to take care of the patient in front of us. Let me give you another story. This is George Washington. Now, George Washington was a larger-than-life figure, and not just in the figurative sense. Literally, he was larger than everybody else at the time. Probably went a long way to him becoming the first president of the United States. Now, back in the winter of 1799, Washington fell ill. course, we don't have great medical records. We don't know exactly what was going on, but it seems that he was suffering from some terrible form of epiglottitis. He was probably septic, probably in septic shock. Now, he's Washington, so he got the best doctors in the country. The best doctors in the country. They didn't know much. They didn't really know what bacteria was or how it was working or how to treat it. What doctors at that time had was a hammer of treatment, and that was bloodletting. That's what they did. They bloodlet. If you were really sick, you got more bloodletting. Now, Washington was a big believer in bloodletting. And I don't mean just killing British soldiers for the Revolutionary War. I mean, he believed, I'm trying to hit home with the Dublin crowd here. He believed that bloodletting was the answer to medical illness. So he told the doctor, take a pint of blood. So they did. He didn't get better. So they took another pint of blood. He didn't get better. So he demanded them to take another pint and another pint and another pint until he died of hemorrhagic shock, which I guess is better than dying of epiglottitis. Now, if this sounds familiar, it's because we had the same problem in 2005 when I was an intern. It wasn't a pint of blood. It was a dose of Lasix, a dose of Lasix, more Lasix, until we killed the patient. So nothing changed in that 205 years. It just shifted a little bit. We like to think that we're not simply a hammer and the disease is a nail, but we weren't able to differentiate out that disease enough to understand how to treat that patient. The pathophysiology of acute pulmonary edema has been understood for 30 years, but we couldn't bring that to the bedside of the patient. We couldn't act on what we knew. And so this spectrum is critical for us to understand. On the urgent end, treatment is very different. Pathophysiology of the disease is very different. On the critical end, the patient has a very different presentation, needs different interventions from us. We need to think differently about that disease. Now, there is an inverse relationship between severity of illness and time to act. The more severely ill the patient is, the less time we have to act, the less time the patient has for us to intervene on their behalf. And this makes this process very difficult. Now, this beckons back a little bit to the idea of thin slicing, because when we have all the time in the world, when we're on that urgent, that mild to moderate end of the disease spectrum, we can take our time. We can use that system 2 processing that Kahneman talks about. If you're not familiar with this, this is the Spock, right? It's cold, it's calculating. It takes all the information in before it makes a judgment. But as the patient becomes more ill, we can't use system 2 as much. We can't rely simply on that. And we flip to Kirk. We shoot from the hip. We take in little bits of information, and we make critical decisions. And we have to be comfortable with both of these. We have to be comfortable with shooting from the hip, but then reanalyzing what we've done and deciding that we were either right or we were wrong and moving forward. So we look at that umbrella term of CHF. We throw it through that prism, and we can spit out on the urgent end of the disease the CHF exacerbation. The patient who had a little bit too much turkey on Thanksgiving, had a couple too many crisps at the pub. They're fluid overloaded. We give them a loop diuretic, and they feel better. They go home. This is what we like to see. But on the other end of that spectrum, we have what Weingart calls the sympathetic crashing acute pulmonary edema. And these patients are not simply going to get a dose of Lasix and go home. The loop diuretic doesn't help these patients. They've fluid redistributed. We have to address this patient far differently than the one with the simple CHF exacerbation. But we lump all of these terms together under this umbrella of CHF. And this is where we go wrong. So what's stopping us? If we understand disease better, if we have medications to treat these different ends, what prevents us from providing better care to the patient that comes in? What stopped us 11 years ago from giving that patient what he needed before he went to the ICU? One of the big ones is the fact that we see far more patients on the mild to moderate end of the spectrum than on the critical end of the spectrum. Right? I see a CHF exacerbation 2-3 times a shift. I see that acute pulmonary edema patient maybe once a week, maybe once a month. And so our brain sees this, it hears or sees, if you're using ultrasound, the B lines, the crackles. We see that, and we default back to the mild to moderate illness. We default back to the CHF exacerbation because it's what we're comfortable with taking care of. There's an inverse relationship between the criticality of illness and the amount of evidence that we have to guide our management. Early on in our career, when we lack experience, we rely on evidence to guide our practice. But we can't do randomized double-blind controlled trials on really sick patients. It's very hard to do that. And so we have little evidence there to guide our management. Now, as we develop our expertise, as we gain experience that builds towards expertise, then we learn how to do this. But early on, we default back again because there is literature, there is evidence to guide us on the mild to moderate end. You can study that group. And time and resources. This is a big part of why we do what we do. The patient's more sick, it takes more of our time, more of our resources. Think about on that mild to moderate end, you got the patient with a little bit of a UTI. You give them a pat on the back and a script for macrobid and they're fine. They go home. Minimal investment of our time and efforts. Now on the other end of that, you've got the uroseptic patient. They need a line, they need labs, they need fluid boluses, they need reassessment, they need antibiotics, they need an ICU. And if you doubt that this happens to all of us, think about the last time you had a septic patient. You gave them the fluid bolus. Their blood pressure didn't respond. And in your hospital, you got to drop a central line to give them pressors. That's a lot of resources. So you gave them another fluid bolus, and another, and another, and another. It's the opposite of what we did to Washington. Instead of taking the patient's blood, we were just giving them fluids. We drowned them. And then 3-4 hours later, 6-7 liters in, the patient still looks like crap. We haven't brought the resources to bear on that patient that we need. This is difficult. The sicker they are, the more resources, the more time, the more of our efforts that patient needs. And that stops us from doing what needs to be done. So this is where we are. This is where we are living now. We are not delivering the best care. We're living sort of in the dark. And we need to move towards that enlightened phase of delivering better care, of understanding the disease in front of us, of understanding the physiology, understanding the treatments, and then ignoring simply that the time is a barrier and making it happen. So how do we do this? I think one of the big keys is education. We need to educate ourselves, we need to educate our trainees how to do this properly. And one of the most critical things, in fact, the thing that I think is the most critical, the thing that you can change tomorrow when you go to work, is the way we name disease. We need to name disease what it is. Call the disease by its name. Stop calling it a CHF exacerbation and call it acute pulmonary edema, because that changes the way we think about it, changes the way our team thinks about it, and it shifts in our mind the resources that that patient needs, the medications that they need, the pathophysiology of that disease. Naming disease is powerful. It gives us power. It empowers us to deliver the proper care. And we need to spend more time at the bedside with that patient. Over the last couple of years, I've seen more and more people in academics who start at whatever number of hours you start at and quickly buy their hours down. They buy their hours lower and lower and lower. And all of a sudden, people are 2-3 years out of training, and they're working 1 to 2 clinical shifts a week. How can you possibly develop expertise in our field, which is so complicated, by working 2 shifts a week? It's not enough. I'm not telling you all to buy your time up. That makes no sense. But we need to invest time, especially early on in our training, into delivering great care. Because if we don't, then how are we going to turn around and teach others to deliver great care if we never learned it for ourselves? And this brings us back a little bit to that original idea of thin slicing, of going to the patient's bedside, of rapidly taking that information in, rapidly deciding where on that spectrum the patient lies. Are they just a little sick, the mild to moderate, or are they critically ill? Do they need everything? They need all of our resources, all of our attention. We have to be able to rapidly identify these patients, rapidly understand what needs to be done, and rapidly deliver those interventions. So how does this work? Right? I've spent 14 minutes talking about how we're doing it wrong. So let's give some examples of how we can do this better, how we can do this right. And some of our previous speakers had quotes from great philosophers. I know Michelle did, and I have my own quote from my favorite philosopher of the 20th century, Bruce Lee. Knowing is not enough, we must apply. Willing is not enough, we must do. Very simple, but it's a very powerful statement. So let's go back to that CHF. Let's throw it through that prism, and we spit out the scape and the cardiogenic shock. We know these diseases are different. We would never bring the high-dose nitrates to the cardiogenic shock patient. We know they need improved flow, and they need to get to somebody else who can help to manage that patient, whether that be CV surgery, interventional radiology sometimes. These patients need more, and they need all of those resources in the hospital rallied around them. This is one of my favorites, allergic reaction. The other night, I was working with a very seasoned veteran nurse who was training a new nursing student, and we had an anaphylactic patient. She looked at the nurse and said, in an anaphylaxis, you have to anticipate the doctor's needs, what medicines they're going to call for. I was kind of like smiling on the inside. I'm like, what a great thing to teach. Anticipate the needs of what's going to come. And she went on to say, in anaphylaxis, they're going to ask for Benadryl and prednisone and maybe even epinephrine. And then I cringed and said, no, that's exactly the opposite of what we need to be talking about. Because we're confusing anaphylaxis and hives under this umbrella term of allergic reaction. For the hives patient, you want to give them Benadryl and prednisone? Make yourself happy. Great. Patient's going to get better on their own. But the anaphylaxis patient needs epinephrine, they need a lot of it, and they need it now. So we have to call the disease what it is. Stop calling it an allergic reaction, call it anaphylaxis. Because when you say anaphylaxis, I think epinephrine. Corey Slovis has this great lecture about electrolytes, where he does like a call and response with the audience. When you hear the word anaphylaxis, your brain automatically goes to epinephrine. So let's call the disease what it is so we can deliver better care. Pulmonary embolism, the bane of our existence as emergency physicians, aside from low-risk chest pain, let's be honest. These two things, PE. PE is another umbrella term. Because on one end, you've got that subsegmental PE. Well, let's be honest. Many of us don't even think this needs to be treated. You want to give them heparin and warfarin, you want to give them a NOAC, whatever. You have all day and all night to think about what that treatment can be. In fact, you can just punt it to the inpatient service if you want to, or you can just send the patient home and let them see somebody else. But on the other end of that, we've got the submassive and the massive pulmonary embolism. These terms in and of themselves are silly, they're stupid. Let's stop calling it submassive pulmonary embolism. Let's call it big fucking clot with RV dilation. Right? That's what it is. And for the massive, let's call it a big fucking clot where the patient's gonna die. Because if we call things what they are, it empowers us to act. The patient with the submassive, with the massive pulmonary embolism, are we really gonna suspect that we can treat them the same as the patient with the subsegmental PE? Now, I don't want to give away my debate with Ian tomorrow, but we're going to get into this. Maybe these patients need lytics. Maybe these patients need catheter-directed lytics. Maybe they need inhaled nitric oxide. But we can't think that these patients are the same. We are punishing our patients by doing so. So this all sounds really simple, but I think some of these things can be very simple. And so this is the challenge. The challenge is to go to work tomorrow or the day after or next week and start calling disease what it is. Stop using umbrella terms. Stop lumping these things together. Let's teach our trainees the right thing. Let's teach them that it's anaphylaxis and not an allergic reaction. Let's teach them that that anaphylaxis triggers the word epi in your head. That it's not submassive PE, it's big fucking clot with RV strain. Don't say fucking all the time, it's not good. Big damn clot. We need to do this so that we can give our trainees the tools that they need to give better care. We need to understand this. We need to understand the nuances of these diseases. We need to understand that we can't treat both ends of the spectrum the same. And remember, knowing is not enough, because we do know we must apply. Willing is not enough. We must do. Thank you very much.
BFC, it's a thing now instead of submassive
Big fucking clot.
PE. Yeah, it's trending on Twitter.
My parents will be so proud.
Yeah. We have to change the ratings of Smack Dub. Anyways, so when we were talking about naming diseases, people had concerns about getting so specific that it could potentially lead to premature diagnostic closure. What are your thoughts on some of the downsides of being so specific? Specifics. I don't speak English, Swami.
It's a good question. I got the same question when I practiced this talk for my residents, is, are we being too specific about this? I don't think so. I think that we need to be specific because the diseases are different. I think calling them all the same thing doesn't make any sense, that there are power with the words that we use. We talked yesterday in our stress inoculation training about how the verbiage that we use can harm or help us. So instead of saying, if I can't intubate the patient, I'll do this, we say, when I can't intubate the patient, I'll do this. Because it commits us. It makes us understand what's coming. As Rich Levitan, one of my mentors, says, Stop calling them difficult airways, call them challenging airways. The verbiage makes a difference. So I'm not saying we need to have early closure, and I think we need to think carefully about these things. And I don't want to overstress the importance of System 1 because System 1 and System 2 need to be used together. But once we know what we're dealing with, we have to call it what it is in order to take care of it. Now, if you defer and you see every patient who comes in who's severely short of breath with a rash and you call them all anaphylaxis and give them epi, how many patients are you going to harm? Probably not too many, if any. On the other side of it, if you call them allergic reaction and just throw some Benadryl and prednisone at them, you're going to harm a lot of people. So I'm not saying that we always defer to the sick end, but when you see it, you know the patient's ill, call it what it is, because I do think there's power with those words. And is that an answer?
I think so.
Or is that just skating around it?
Both. Thanks.